Introduction to clinical pharmacology. Clinical pharmacology is the study of how drugs interact with the human body to treat or prevent disease. It focuses on the safety, effectiveness, and personalized use of medications to ensure the best therapeutic outcomes. The key concepts in clinical pharmacology includes understanding pharmacokinetics, how drugs move through the body, pharmacodynamics, how drugs affect the body, and the role of therapeutic drug monitoring. Key points we are going to discuss: role of clinical pharmacology in modern medicine, personalized medicine in pharmacogenomics, monitoring and managing drug therapy in patients. I'm going to share a sample case study here. A 55-year-old male with hypertension and diabetes is being treated with metformin and lisinopril. He develops a dry cough after starting lisinopril and returns to his doctor for an evaluation. Let's discuss. This case highlights the need for understanding drug side effects and the importance of tailoring therapy to individual patients. ACE inhibitors like lisinopril can cause a dry cough in some patients, necessitating a switch to an alternative drug, such as an ARB or angiotensin II receptor blockers. Let's discuss clinical vignette-like question. A 55-year-old man with a history of hypertension and diabetes type 2 presents to the clinic with a persistent dry cough for the past 2 weeks. He started lisinopril 3 weeks ago. Physical exam and chest x-rays are unremarkable. Which of the following is the most appropriate next step management? In this question, we have to be able to differentiate between actual disease or possible drug side effects that patient has been given. In this scenario, we should pay attention to possible respiratory tract infections such as pneumonia. Or we should pay attention that if patient is having any side effects from the given medications for his existing illnesses. The correct answer to this question is going to be discontinue lisinopril and switch to an ARBs. Explanation. ACE inhibitors are known to cause a dry cough due to the accumulation of bradykinin. Switch to an ARBs, which does not cause this side effect, is the most appropriate next step. Now let's discuss about adverse drug reactions. Adverse drug reactions are unwanted or harmful effects experienced with normal drug use. Adverse drug reactions can be dose-dependent, toxicity from overdose, allergic reactions, or due to drug interactions. In modern medicine, adverse drug reactions are leading cause of hospitalizations, especially in patients with polypharmacy, taking multiple medications. Key points to remember is adverse drug reactions classified by dose-related problems, allergic reactions, or drug interactions. Importance of monitoring for adverse drug reactions in elderly or polypharmacy patients. Common adverse drug reactions by medication classes can be ACE inhibitors. The side effect could be dry cough or angioedema. The sample medication we can take is lisinopril or any medication that belongs to this group. Non-steroidal anti-inflammatory medications. Their well-known side effects are GI bleeding and renal damage. Ibuprofen is one example for that group. Anticoagulants, their most common side effect is bleeding. The warfarin is the one example for that. Opioids, they can cause constipation and respiratory depression. The one member of that group is a morphine. Let's discuss sample case study to reinforce your learning here. An 80-year-old female patient with osteoarthritis has been taking ibuprofen for chronic pain. She presents to the emergency room with melena, black stools, and a drop in hemoglobin levels. When we discuss this case, we have to pay attention that this patient is taking NSAIDs for chronic pain. In this case, it's an ibuprofen. It can cause gastrointestinal bleeding, especially in elderly patients. This case underscores the importance of monitoring for adverse drug reactions, particularly in high-risk populations. We can make a clinical vignette questions out of this case. Let's take a look. An 80-year-old woman presents with black stools and fatigue. She has been taking ibuprofen for osteoarthritis. Her hemoglobin level is 9.2 grams per deciliter. That came down from 13 grams per deciliter 3 months ago. Which of the following is the most likely cause of her symptoms? The correct answer to this question is going to be peptic ulcer disease. Let's explain briefly. Long-term NSAID use is a major risk factor for peptic ulcer disease, which can lead to gastrointestinal bleeding. The patient's melena and drop in hemoglobin levels are indicative of an upper GI bleed. Next, let's talk about polypharmacy and drug interactions. Polypharmacy refers to the concurrent use of multiple medications often seen in elderly patients or those with chronic diseases. Drug interactions occur when one drug affects the metabolism or action of another, potentially leading to reduced efficacy or increased toxicity. Key points to pay attention: the importance of reviewing patient medication lists, recognizing high-risk drug combinations. These drug interaction pathways we should be aware of: absorption interactions, antacids reducing absorption of fluoroquinolones. Second is metabolism interactions, warfarin and metronidazole leading to increased anticoagulation effect. That happens through cytochrome P enzyme inhibition pathway. Third example is going to be excretion interaction. NSAIDs reducing renal clearance of methotrexate. When given the NSAIDs with methotrexate, the methotrexate level can increase in human body because of the reduced of renal clearance of the medication. Let's discuss sample case study. A 72-year-old man with atrial fibrillation is on warfarin for anticoagulation. He is prescribed metronidazole for a dental infection and develops significant bruising. Here, metronidazole inhibits the metabolism of warfarin, leading to an increased risk of bleeding. Careful review of medications and dose adjustments based on interactions is critical in such cases. Let's discuss a sample question here. A 72-year-old man on warfarin for atrial fibrillation is prescribed metronidazole for a dental infection. 2 days later, he notices bruising on his arms and legs. When we test the INR, it came out 5.1. Which of the following best explains these findings? The correct answer to this question is inhibition of warfarin metabolism. Inhibition of warfarin. Let's explain this. Metronidazole inhibits the cytochrome P450 enzymes that is responsible for warfarin metabolism, leading to elevated INR and an increased risk of bleeding. Next thing is pharmacovigilance and drug safety monitoring. Pharmacovigilance involves the monitoring of drugs after they are marketed to detect rare or long-term adverse effects. This is crucial for ensuring drug safety and preventing large-scale harm. Key points to remember here is importance of post-marketing surveillance, reporting systems for adverse effects such as FDA's MedWatch. Let's discuss about some examples of medications that give adverse reactions post-marketing. First medication is rofecoxib. Reported adverse reactions was increased cardiovascular risk. As a result, it was withdrawn from the market. Another drug example is thalidomide. Reported adverse drug reactions were birth defects. As a result, applied restricted use of these medications, especially in pregnant population. Another group is statins. Adverse reactions they caused was muscle pain, rhabdomyolysis. Therefore, dose limitations and drug monitoring was applied. Sample case study here we can use is a new diabetes medication is released, and after 6 months and several patients report muscle pain and weakness. Post-marketing surveillance reveals an association with increased risk of rhabdomyolysis. This case illustrates the importance of ongoing monitoring after drug approval, as a rare side effects may not be detected during clinical trials. Let's discuss the question scenario, clinical vignette question scenario. A new cholesterol-lowering medication is introduced, and 6 months later, several patients report muscle pain and elevated creatinine kinase levels. Which of the following actions should be taken by regulatory authorities? The correct answer here is monitoring for rhabdomyolysis and dose adjustments in the high-risk patients. Post-marketing surveillance allows for identification of side effects not seen in clinical trials. In this case, monitoring and dose adjustments should be considered for patients at high risk of muscle toxicity. Next important thing we want to discuss is personalized medicine and pharmacogenomics. Pharmacogenomics studies how genetic variations affect individual drug responses. By tailoring drug therapy to a patient's genetic profile, doctors can improve efficacy and reduce possible adverse effects. Key points to remember: genetic testing for drug metabolism, such as cytochrome P450 enzymes, impact on treatment decisions, particularly for anticoagulants, psychiatric medications, and chemotherapy patients. Here are 3 personalized medicine processes. First, genetic testing. Identify genetic polymorphism, such as cytochrome P2C9 for warfarin. Second, drug selection. Choose medications based on patient's genetic profile. Third, dose adjustments. Tailor those to optimize efficacy and minimize toxicity. Let's discuss sample case study. A 60-year-old female with atrial fibrillation requires anticoagulation. Genetic testing reveals she's a poor metabolizer of warfarin due to cytochrome P2C9 polymorphism. Based on this genetic profile, doctor switches from warfarin to direct oral anticoagulant, which is less influenced by genetic variations. Let's take a look at this clinical vignette question. A 60-year-old woman with atrial fibrillation is started on warfarin. Genetic testing reveals she is a poor metabolizer of the warfarin due to genetic polymorphism. What is the most appropriate next step in management? Correct answer to this question is going to be switch to a direct oral anticoagulant, such as apixaban. And to explain this question, poor metabolizers of warfarin are at increased risk for bleeding due to slow clearance of the drug. Switching to direct-acting anticoagulants, which does not rely on this cytochrome enzyme metabolism, is a safer and more effective option. In today's lecture, we discussed fundamentals of clinical pharmacology, concepts such as drug safety, adverse reactions, personalized medicine, genetic variations in pharmacogenomics. Real-life scenarios and cases we used in here is to reinforce your learning processes. We wanted to make sure that you can apply this knowledge into your clinical practice. Thanks for watching and take care.